We are going to speak about the prolonged seizure and status epilepticus in Dravet syndrome. This is my declaration of conflict of interest. And as you know, prolonged seizure and status epilepticus is a distinctive feature of Dravet syndrome, and the incidence is around 70-90% of the patient present prolonged seizure and status epilepticus. In the case series of XU in the 2014, 71% of patients present seizure longer than 15 minutes, and nearly half of the patients present seizure longer than 30 minutes. And the age of onset is usually the first year of life, with a mean around the 6 months. And as you can see, in the case series of Ragona, status epilepticus was in 1/3 of the patient the first seizure. And the status epilepticus, the recurrence of status epilepticus is a distinctive feature of Dravet syndrome. As you can see on the right, there is a comparison between Dravet syndrome and protocaderine 19 related epilepsy, and you can see has prolonged seizure, repetitive prolonged seizure is a distinctive element of this syndrome. And when we are faced with a child with status epilepticus, when is likely to have a Dravet syndrome, there is this very interesting case series of Legalis, a Switzerland group. They analyzed 71 children with status epilepticus, and in the 4 years they are the age was around 44 years, and they found the mutation, SSN-A mutation, in 12 patients. 10 was affected by Dravet syndrome, and 2 by GEFS+. That means that this gene mutation was found in around 17% of the patient. But if we consider the status epilepticus during the first 18 months of life, and if we consider the presence of more than one status epilepticus, that means the repetition, the fact that the patient presents repetitive status epilepticus, the risk of Dravet syndrome increased to more than 50%, 56%. And we can have different type of seizure and status epilepticus. The more famous is the unilateral or so-called generalized prolonged seizure status epilepticus. The age is around 13 months. That means during the first year of life, with a mean around 6 months. The duration is variable. What is very interesting is that you can find the majority of patients some precipitants. That means fever, cold, water bath, stress, physical exercise. And the semiology usually is hemiclonic seizure with variable side. And when the clonic jerks became bilateral, some author can consider as generalized seizure. And you can see the patient start a seizure is involving the left side, maybe not so evident, but if you can see very brief clonic jerks involving the left side, and the same patient a few months later present another seizure, more involving the right side. I think you can see. You can see? Okay. And if the seizure persists, became bilateral, and is always the same patient. If the seizure persists, became bilateral, can involve the face, and you can see there is cyanosis, chalorrhea, and so on. And there is a progression of the seizure, unilateral, then bilateral, then so falsely generalized. They can be very, very prolonged. Another type of status epilepticus is mainly focal, usually is observed later on respect to the unilateral, is clearly a focal seizure, very prolonged focal seizure, and in this patient there has precipitant fever, stress, but also intermittent photic stimulation, and the patient usually presents staring, slow head and eye deviation to one side. This side can change during the same seizure. And actually, we can find the picture of the non-convulsive status epilepticus. Here you can see one of our patients after intermittent photic stimulation. He presents stirring. He starts to have a right, slow, high head deviation. You can see here. The seizure can be very subtle. Sometimes it's not recognized as a seizure, but also the patient presents a decrease of reactivity, as you can see here, and the seizure may be very prolonged, and you can have a non-convulsive status epilepticus. So as you can see here, you can have a prolonged seizure. In this patient is an occipital seizure involving the left posterior area, and the seizure persists at least 5 minutes. And this is another identical case, exactly the same semiology provoked by intermittent light stimulation. That is maybe more prolonged. This is a seizure lasting more than 20 minutes. This is also because this non-convulsive status sometimes is very difficult to recognize, and it's obvious that if you have the help of EEG, you can understand that the patient is having a status epilepticus. And the third type of status that is very similar to the previous one, perhaps, is the obtundation status described first by Bernardo alla Bernardina. And the age can be, the patient can be older because it has been described also in patients of 19 years old, and is characterized by impairment of consciousness, fragmentary, segmental, erratic myoclonus that can involve the limbs, the arms, and the face, and also some tonic and clonic movement shifting from one side to the other. And the DG is characterized by erratic discharge spreading from one hemisphere to the other. And if the seizure persists, you can need a respiratory support. Usually, we know that status epilepticus can affect the course, the long-term course of Dravet syndrome, but usually is rarely observed on the short term psychomotor and cognitive decline. In 2010, the group of Rimanabu published this paper in which they present 3 patients with the unusual consequence of status epilepticus, and these patients present a very severe cognitive and motor deterioration following a refractory status epilepticus lasting respectively 2, 7, and 12 hours. And they describe the appearance of a progressive cerebellar and cerebral atrophy. Few months later, demonstrated with the MRI that you can see, and they suppose that this can be the consequence of anoxic ischemic-like lesion, although cardiovascular function had remained stable. Actually, they then arrived to demonstrate hemodynamic failure, nor abnormality of cardiac rhythm in this patient. And also they speak about the etiology and the pathogenesis of this condition, they consider also the responsibility of the phenobarbital and the barbiturate. Early this morning we already discussed about that, but this was just an hypothesis. And later on, 2 years later, Okumura published this very interesting paper. They present 15 patients with an acute encephalopathy in patients with the Dravet syndrome, in which they present coma and very severe consequence, a cognitive and motor consequence after a status epilepticus followed by coma. And they present 15 patients. The age range from 1 year to 15 years. And you can see the sequelae, very severe sequelae from a cognitive and motor point of view, but also they have 4 patients who died after this situation. And this is the treatment followed during the status epilepticus. The majority of patients has been treated with benzodiazepine or more than one diazepine. Just 2 patients were treated with phenobarbital. And what is interesting is if you analyze the chronic treatment, the previous treatment, no one of these patients was taking stiripentol. And this is the lesion found in this patient. As you can see, the brain lesion on the MRI, on the fusion-weighted images, can involve the cerebral cortex, the deep gray matter, but also the white matter and the subcortical structures. And different from this condition, but perhaps there are some element in common, is the case series recently presented by the group of English Schaeffer. The first name is Myers, and they present 5 patients with fatal cerebral edema with the status epilepticus, and all these patients present a de novo SSN1A mutation. The age range from 5 to 11 years. Just one of these patients was taking stiripentol as a chronic treatment, and what is characteristic, they present a fever and hyperthermia very severe, more than 40 degrees, associated with status epilepticus. Just 2 of these 5 patients was being treated with phenobarbital. And clinically, they present the brainstem dysfunction with a cerebral herniation due to this very severe malignant cerebral and cerebellar edema. And the comment of the authors was that this edema, it was far more severe than imaging change typically seen after convulsive status epilepticus, suggesting this phenomenon may be specific to Dravet syndrome. And as I showed you before, the role of the phenobarbital has been criticized, but if we try to find the literature how we can treat the stable phase of the status epilepticus Dravet syndrome, there is very few papers, and the most important is this paper by Tanabe, published in 2008. He says that the best drugs, the most efficacious drug actually was for the control of the status epilepticus was intravenous barbiturates and intravenous midazolam. That's been that we can discuss about the role of the phenobarbital in the treatment of the status epilepticus. But why the patient with the Dravet syndrome may have so severe consequence of prolonged seizure status epilepticus? Why this patient already treated can present so severe conditions, so severe acute encephalopathy? There are some elements in common in this patient, this series of patients. Obviously, the gene mutation, the fever, very severe hyperthermia, and the treatment failure. That means that the same drugs that in previous status epilepticus was efficacious in this condition present failure. And we can discuss, just to present some element that can be object of discussion, that in Dravet syndrome, the gene mutation impair the GABA transmission. We already know this aspect. And in Dravet syndrome, there is a specific, peculiar fever sensitivity, and there are a lot of seizure-induced hyperthermia, hyperthermia-induced seizure, and this malignant evolution arrives just after fever, not after other precipitant factor. And the febrile context also worsen in the sodium channel disorder, the insufficient, and therefore decrease the GABAergic inhibition. And we know there are some data in the literature that has been supposed that the chronic treatment with benzodiazepine can reduce the efficacy of benzodiazepine used during the status epilepticus, and also the efficacy of phenobarbital and diphenyldantoin. And as you know, the gold treatment of the Dravet syndrome is valproate, clobazam, and stiripentol, as already present today. And also the presence of repetitive status epilepticus increase the NMDA excitability. And as final consideration that we can discuss later, all these mechanisms decrease the GABAergic inhibition and increase NMDA excitability, and this can explain the failure of the treatment and the origin of this acute encephalopathy. And but we know that actually stiripentol can prevent status epilepticus, thanks to the courtesy of Rimanabu, and I would like to show this data regarding the coincidence with the addition of the stiripentol to the treatment and the decrease of number of status epilepticus. And there is recently a review by Miles and Ingrid Scheffer confirming that the frequency of status epilepticus is reduced in 40% of patients with Dravet syndrome after stiripentol initiation. And just to finish my presentation regarding the rescue medication, that means the medication that we have to use at the onset of the seizure, and mainly the rescue medication used in a pre-hospital setting. As you know, it's very important an early treatment is very important, and if you treat our patient with the delay, the benzodiazepine the efficacy of benzodiazepine can decrease. And there is this sentence by Chin. He say, for each minute delay from onset of convulsive status epilepticus to arrive at the accident and emergency department, there was a 5% cumulative increase in the risk of the episode lasting more than 60 minutes. And just to remember that at the onset of the seizure, we have to use benzodiazepine, and mainly diazepam and midazolam. At least in Italy, you cannot use lorazepam in a pre-hospital setting. And these benzodiazepines are very useful in different type of formulation, mainly rectal for diazepam and buccal oromucosal for midazolam. And actually in Italy, the rectal diazepam is the most frequently used drug for rescue medication. And just to remember that there are some studies comparing the efficacies of oromucosal midazolam versus rectal diazepam, and they arrive to demonstrate that oromucosal midazolam is effective as rectal diazepam, or just a little more effective. And also there are some data in the literature about suggesting the use of intranasal therapy, mainly with midazolam or lorazepam for the initial phase of prolonged seizure status epileptico. Just to conclude this aspect of the rescue medication with this very recently review by Cochrane, the first name is McTaggart, they confirm that the best treatment actually apparently is the intravenous lorazepam and diazepam, because they lead to more rapid seizure cessation, but in a pre-hospital setting, the time taken to obtain the intravenous access may undermine this effect. That means that we have to use the non-intravenous formulation, and buccal midazolam and rectal diazepam actually are therefore acceptable as first-line anticonvulsant for the treatment of an acute prolonged seizure. And until now, there is no evidence to support that the use of intranasal midazolam or lorazepam is actually an alternative until now to buccal midazolam or rectal diazepam. That means that rectal diazepam or mucosal diazepam actually they have similar efficacies. That means that our choice has to be based on other elements, and thanks to again to the Paola De Liso and Riman Abu, I would like to present you the result of this survey performed in Paris with 50 families of patients with the Dravet syndrome, and they analyzed in this case series 4 elements: the ease to administration route, the drug preparation time, the efficacy, and the social acceptance. And as you can see, the efficacy is nearly the same. This is the rectal diazepam, 78% versus 83%. But the ease of administration is just 10% in rectal diazepam versus 63% in orobucosa, in buccal midazolam. And the drug preparation time is around 2-3 minutes for the rectal diazepam versus less than 1 minute for the buccal midazolam. And the social acceptance is clearly, absolutely prevalent in favor of buccal midazolam. And this confirmed the data. And just to conclude my presentation, repetitive prolonged seizure and status epilepticus are actually a distinctive feature of Dravet syndrome. And the semiology of status epilepticus is variable and can change according to age. And the majority of status epilepticus recognize a precipitant factor, but is assured that the fever is the most frequent and the most dangerous precipitant or factor. And in few cases, also if they are correctly treated, we can observe a malignant evolution associated with fever and infectious episode. And actually it's confirmed that stiripentol can reduce the frequency of status epilepticus, but the role of benzodiazepine used chronically and the role of phenobarbital used during the treatment of status epilepticus should be investigated. And to conclude, as concerned the rescue medication, no, I don't. Is that okay? To conclude, the efficacy of different non-intravenous rescue medication is similar, but buccal midazolam is more likely to be accepted and easier to be administered by parents and caregivers. And I would like to thank my collaborator, the epilepsy team, and mainly Paola De Liso and Marina Trevisano. They helped me for this presentation. Thank you. Thank you very much.
Thank you, Federico.